All right, let's dive into the world of neuro-oncology. Now, whether you're a med student just starting your neurology rotation, or maybe you're a resident just looking for a quick brush up, this guide is designed to give you the key fundamentals you need to approach patients with brain tumors with a whole lot more confidence.
So, what's our game plan? First, we're going to build a solid foundation, our general approach to any patient who might have a brain tumor. Then, we'll get into the weeds on metastatic tumors, because honestly, they're the ones you're going to see the most. From there, we'll take a look at the most important primary tumors, and we'll wrap things up with the really critical stuff, managing the life-threatening complications that you absolutely have to be ready for.
Okay, let's start at square one. A patient comes in with some new neurologic symptoms. Your first thought, your first question, should always be, where is the problem? See, in neuro-oncology, a patient's symptoms are basically a treasure map, because that location, well, it's everything. And take a look at this. It's basically your clinical cheat sheet. If you have a tumor hanging out in the frontal lobe, you might see big personality changes, or maybe some weakness. But what if the mass is in the cerebellum? Well, then you're on the lookout for things like ataxia and balance problems. This is how you start to solve the puzzle before you even order a scan. Now, besides those specific focal signs, you've got to be on super high alert for signs of elevated intracranial pressure, or ICP. Just remember, the skull is a fixed box. It doesn't stretch. So any tumor that's growing in there can turn it into a dangerous pressure cooker. So what are the red flags? Nausea, blurry vision, and that classic headache that gets way worse when someone coughs or strains. These are huge warning signs of a neurologic emergency.
So, here's a super practical point for when you're on call. A patient comes in, sudden change in mental status. You need answers fast. A non-contrast head CT is your go-to tool to quickly rule out a big bleed or, worst case, herniation. But, and this is a big but, to really truly see a tumor and understand what you're dealing with, you need a brain MRI with contrast. It's like the difference between a grainy old photo and a 4K video.
Okay, so we've got our general framework down. Now let's talk about the single most common type of brain tumor you're going to see in adults, and that's metastatic tumors.
And here is a high-yield fact for your exams and for the wards. Tumors that spread to the brain from somewhere else in the body are way, way more common than tumors that actually start in the brain. It's just a numbers game, and the odds are stacked in favor of metastases.
So you're probably asking, where do these things come from? Well, the usual suspects are lung cancer, breast cancer, melanoma, and kidney cancer. So the moment you see what looks like a metastasis in the brain, your detective work immediately broadens to find where it started.
And when you get that contrast-enhanced MRI back, you'll often see this classic picture. Metastases just love to set up shop right where the gray and white matter meet, and they usually show up as these distinct ring-enhancing lesions. It's like a little glowing halo around the tumor, and when you see a bunch of them, it's pretty much a dead giveaway for metastatic disease.
All right, so we've covered the tumors that travel to the brain. Now let's switch gears and focus on the really important tumors that actually grow from within the central nervous system itself. And first up is the meningioma. You can think of this as the good news tumor of the brain, relatively speaking. It's the most common primary tumor, and the great thing is it's almost always benign. You know, a lot of these are actually found completely by accident on scans that were ordered for something else entirely, like a headache or after someone bunked their head. And this image right here, it's the textbook definition of what they look like. It's a dural-based tumor, which means it's growing from the coverings of the brain, the dura, and see how it lights up, bright and uniform, kind of like a light bulb? Plus, it often has this classic dural tail that tracks along the dura. That is a huge diagnostic clue. Now, on the complete opposite side of the coin, we have glioblastoma. This is the most common and, unfortunately, the most aggressive and deadliest primary brain tumor in adults. It's a really tough diagnosis and one you need to be prepared for. And its appearance on the MRI really tells the story of how aggressive it is. You know, unlike that smooth, neat meningioma, a glioblastoma is usually this big, messy, infiltrative mass. It has this irregular enhancement around the edges and a dark, necrotic center where the tumor has outgrown its blood supply. And you can also see all that swelling around it, which just speaks to its destructive power. The prognosis is, well, it's very poor. Even with the absolute best treatments we have, surgery, radiation, chemotherapy, the 5-year survival rate is still under 10%. We're often talking about survival in terms of months, not years. And
that is just a devastating reality for these patients and their families.
Okay, now for a really important clinical pearl about another primary tumor called CNS lymphoma. These tumors are incredibly sensitive to steroids. So if you think a patient might have lymphoma and you give them dexamethasone before they get a biopsy, the tumor can shrink like crazy or sometimes even look like it's vanished on the scan. We call it a ghost tumor, and it can make getting a real diagnosis almost impossible.
Just diagnosing the tumor is really only half the battle. So let's talk about how to manage the critical, life-threatening complications that can pop up.
So picture this. You get that dreaded page. Your patient with a known brain tumor is suddenly unresponsive. You sprint to the bedside, you check their pupils, and they're fixed and dilated. This is it, the ultimate neuro-oncologic emergency, brain herniation. The clock is ticking. What do you do right now?
These 4 steps are your life-saving bridge to get the patient to more definitive treatment. Okay, 1. Get the head of the bed up to 30 degrees to help blood flow out of the brain. 2. Hyperventilate them to constrict the blood vessels. 3. Give hyperosmolar therapy like mannitol or hypertonic saline to literally pull water out of the brain. And 4. Push IV dexamethasone to reduce the swelling. You have to do these things immediately.
Here's another key management point, this time about seizures. It's a question that comes up all the time. Should you just put your patient with a brain tumor on seizure meds just in case? And the answer, according to current guidelines, is no. You should not start prophylactic anti-epileptics if they haven't actually had a seizure. Now, if your patient does have a seizure, your choice of medication really matters. You generally want to steer clear of the older drugs, like phenytoin or carbamazepine. Why? Because they have a ton of drug-drug interactions, which is a huge headache when you're also giving chemotherapy. The newer drugs like levetiracetam are much preferred. They have a better side effect profile and far fewer interactions.
Okay, this next point might feel a little wrong at first, but it's so important. Patients with brain tumors are at a super high risk for blood clots. And I know what you're thinking. Aren't we worried about causing a bleed inside the tumor? And yes, we are. But the risk from an untreated clot, like a pulmonary embolism, is generally considered way higher. So for a confirmed clot, anticoagulation is still the standard of care.
And finally, always remember that the tumor itself isn't the only thing that can cause problems. You have to keep these things called paraneoplastic syndromes on your radar. They're these fascinating, sometimes bizarre disorders where the body's immune system tries to attack the cancer, but accidentally attacks the nervous system instead. Take limbic encephalitis. It can show up with sudden memory loss and behavioral changes, and it can look for all the world like a super fast-moving dementia.
So what's the big takeaway here? It's that neuro-oncology is so much more than just being able to read an MRI. It's about being a great clinician. It's about anticipating that whole cascade of problems, the seizures, the swelling, the blood clots, and managing them proactively. It's about taking care of the entire patient, not just the picture on the screen. And that right there is what will make you a truly fantastic doctor.